Good evening, everyone, and welcome to tonight's webinar, Cryoneurolysis for Post-Surgical Pain. Post-surgical pain is one of the biggest challenges in modern medicine. Cryoneurolysis, a minimally invasive technique that applies extreme cold to peripheral nerves, offers a promising path to reduce pain and improve outcomes. Our speaker tonight is Dr. Arun Kalava. Dr. Kalava is double board certified in anesthesiology and pain therapy, fellowship trained at the Mayo Clinic, chairman of the American Society for Post-Surgical Pain, founder of TampaPainMD and Ultrasound Experts, and an internationally recognized educator in ultrasound-guided pain interventions. This evening, he'll share an evidence-based overview of cryoneurolysis, including its mechanisms, key nerve targets, safety considerations, and the latest clinical evidence. We'll conclude with a live Q&A, so please note your questions as we go. It's my pleasure to introduce Dr. Kalava.
Thank you, Nick. Thank you for the introduction. Everybody who's joining us, thank you for joining us this late in the day. I'm going to get started here. So these are the conflicts of interest I have to declare. Today's agenda is going to be talking about basics of cryoneurolysis, the mechanism of action, different cryosystems that are available in the United States, contraindications to cryoneurolysis, and we'll talk extensively about cryoneurolysis of various nerves to manage post-surgical pain. Before we dwell into it, I would like to mention that we have 2 workshops coming up. These are the only workshops, I'm mentioning again, it's the only workshops in the United States that teach cryoneurolysis. One coming up in a couple of weeks and one in February in San Diego. So I'm going to give you this page, give you a few seconds to scan the QR code if you're interested in learning more about it and seeing us for those workshops if you want a hands-on experience. On the same note, the American Society of Post-Surgical Pain has its annual conference here in Tampa, Florida in December. So we would welcome you to join us for a wonderful faculty from around the world. We have 2 exclusive workshops that are included in your registration fee. One focused on the acute pain and the chronic pain. This is acute post-surgical and chronic post-surgical pain, and how to use your ultrasound skills to manage those patients. I'm going to give a pause here so you can scan the QR code to learn more about the annual conference. It's going to be happening December 6th and 7th in Tampa, Florida. So you want to escape some cold weather? We're in Florida, welcoming you over. A few more seconds for people who want to scan the QR code to learn more about the conference coming up. Now, before we start the topic, I just want to touch base on the evolution of pain, primarily the post-surgical pain. Acute pain primarily dealt with during the perioperative period by the anesthesiologists and surgeons alike. A lot of the societies and everybody else focused on acute pain, and nobody really talks about transitional pain or chronic post-surgical pain. The transitional pain is pain before the acute pain becomes chronic. Now, transitional pain is mostly seen by the emergency docs and primary care docs, who are obviously now well-equipped to treat. So the onus falls on the surgeon and the anesthesiologist to take care of that. When it comes to chronic pain, same thing. Chronic pain docs are primarily trained in treating spine-related pain, and they're now well-equipped to treat post-surgical pain. So the whole science has to evolve, and I think it's still in its infancy as to how to treat transitional and chronic pain, which is not really talked about if you go to many societies, any conferences or workshops. We're about to change that and then focus on acute, transitional, and chronic post-surgical pain. Let's talk about basics. Well, how does ice form on a needle tip? Well, it's called Joule-Thomson effect. When a gas flows from a high pressure to a low pressure chamber, it expands and then forms an ice ball. The drop in pressure causes extreme temperatures, which will form an ice ball. There are different systems. One is EpiMed. It can be run on nitrous oxide or carbon dioxide. The maximum temperature is -70 degrees Celsius. Boston Scientific runs on argon gas-based technology. It's Argon gas is more expensive than nitrous and carbon dioxide, something to keep in mind for your hospitals and facilities and outpatient procedures. Some of you might have known about AtriCure, which is an intraoperative procedure wherein the surgeon actually applies cold, and it's been studied for many, many years, used for thoracic pain. Now they also have something for the amputation. So it's a direct application intraoperatively, not for the anesthesiologists or the chronic pain physicians or ER physicians or primary care physicians. There's only one handheld system. It's called the iOvera. It is FDA approved for peripheral nerve of sensory origin that you can treat. This is how it's going to look like. There's two different needles, a short needle and a long needle. This is a nitrous cartridge which goes into the device. We'll talk about nerve anatomy quickly so you understand what I'm trying to say today. The nerve has endoneurium, perineum, epineurium. These are the coverings outside the nerve. When we do a cryoneurolysis with iOvera or other cryoneurolysis equipment available in the United States, the temperature stays within the second-degree nerve lesion, which is axonomesis, where there's loss of axon, but the endo, peri, and epineurium are intact. There's Wallerian degeneration and a full reversible loss. So these procedures are 100% reversible because we are at the first and second degree when it comes to cryoneurolysis. So neurolytic treatments, they use heat, radiofrequency ablation, or cold. Cryoablation is irreversible. The temperatures obtained are minus 140 degrees Celsius. The handheld device, which I commonly use, goes to minus 88 degrees Celsius. What are the contraindications? Very important to know when not to do cryoneurolysis. Somebody has Raynaud's syndrome, lack of blood supply, right? Cryoglobulinemia, which is very uncommon, but something to keep in mind. Cold urticaria. You see this image here. This patient actually had cryoneurolysis, one of her forearm nerves, and she developed these blister-like things. She has cold urticaria. If we knew, we would not have done the case. Bleeding disorders, again, risk versus reward. Localized infection, absolute no-no, right? Anticoagulations, same applies as a bleeding disorder. Anatomic inaccessibility. If it's difficult to perform, then you have to abort. Effectiveness and safety data that iOvera, the handheld system we have, I'm going to talk about. As you already mentioned, there's a second-degree nerve injury that results following cryoneurolysis. At 2 weeks, if you look at this image, this is an untreated nerve. At 2 weeks, the axon and myelin have degenerated. At 4 weeks and 8 weeks, you start seeing the green. That means the axon is being regenerated. Similar microscopic structure. What about the adjacent tissue? That I get asked that a lot. So at 8 to 32 weeks post-treatment, blood vessels, flat tissue, and surrounding muscles appear normal on histology. Lumens of small arterioles remain patent. So it's a very simple, safe procedure to do. So nothing to worry about the blood vessels around or the muscles around. So if you're treating acute pain and you know what surgery is being done and what is the dermatome or the nerve supply that the surgery would need to be frozen, you don't need to do a diagnostic nerve block. You can go ahead and do the cryoneurolysis. But if you are treating, let's say, post-surgical neuralgia in the subacute phase or the transitional phase or a chronic pain, then you want to identify and give the patient a simulation, also give yourselves a roadmap as to what you have to do when you're doing a cryoneurolysis. So here's an ultrasound probe you will need. You will need a nerve stimulator because a lot of the times that's a very good thing to have. Even though you see the nerve, you want to make sure if it's the nerve that you're targeting, and primarily we're targeting sensory and some mixed nerves. What about the tools for cryoneurolysis? As you see, I'm using the iOvera handheld system. There's an 18-gauge IV catheter which is used as an introducer because the needle tip is blunt. The cartridge, a nerve stimulator which can be attached to this cryo needle, so you can actually stimulate the nerve if you want to and if you need to. And if it's a very small nerve, which you cannot really identify on an ultrasound, but I think the stimulation would certainly help you, the patient's awake. So let's talk about the targets since we finished the introduction: head and neck, upper extremity, trunk, pelvis, and lower extremity. Head and neck targets. Where would I do greater and lesser occipital nerves? Well, if you have a cranial surgery, a craniotomy, an occipital procedure wherein the tumors are being removed, that would be a case where you would do occipital nerve blocks. Most of my patients see me after their surgery, so I'm seeing them in the subacute or chronic post-surgical pain situation. To talk about occipital nerve, this comes from the C2, medial branch of the dorsal primary rami. If you look at the image, here's the occipital nerve running along close to the midline. There's two of them. And it lies between the semispinalis capitis and the obliquus capitis inferior. So when you're using ultrasound, you have to find the semispinalis capitis and obliquus capitis inferior, and the nerve is in the fascial plane between those two. So probe position is usually a high-frequency probe along the C2 vertebra. Here's a video of an occipital nerve scanning, the greater occipital nerve. So we see semispinalis capitis, obliquus capitis inferior. Here we're going to the occipital protuberance. I'm coming down, coming a little lateral, finding those two nerves. I think I just saw the occipital artery just pulsating a minute ago when we started. So there's the artery pulsating. Here's how the injection looks like after you do the occipital nerve block. So here's an actual demonstration of a nerve block performed in plane. Again, the techniques are in plane and out of plane. So we have a fascial plane with a very inconspicuous nerve, to be honest. So in this situation, you would want to use a nerve stimulator wherein the patient would give a feedback. Yes, doc, your needle is next to the nerve. Then you confidently can inject or do a cryoneurolysis. Here are the images of patients getting cryoneurolysis. These are, as mentioned, post-surgical chronic or subacute pain. This is a greater occipital nerve. We're approaching lateral to medial. Here's a greater occipital lateral to medial as well. Look at the patient position. Patient positioning is usually lateral decubitus. Here's a lesser occipital. You can actually see scars on this gentleman who had a meningioma resected and still had significant pain along the lesser occipital. I'm going medial to lateral in this aspect. You see the angiocath, which is actually giving us access into the skin because it's a blunt needle, also preventing any freeze around the skin and the frostbite on the skin. Upper extremity targets, you'd be surprised, you can freeze the entire brachial plexus. And if you've not heard about this case, it's about time you do. This was a gentleman in a motor vehicle accident, lost the entire upper limb. They did a forequarter amputation, and intraoperatively after the surgery, they froze the entire brachial plexus. But the patient had no acute pain or chronic pain for 6 months. A surgery like this, it's a nightmare of a pain control for the surgeon involved and the anesthesiologist, the primary care, ER docs, physiatrists, everybody involved in the care. But one little probe, as I said, this is an intraoperative probe placement at minus 60 degrees Celsius for just 2 minutes. You're not taking a lot of time. The outcomes are superb. When it comes to different nerves in the upper extremity, suprascapular nerve is a very good target. As you know, it covers close to 70% of the shoulder. Here's the scanning of the suprascapular nerve. We have the scapula, suprascapular notch, tarsoscapular ligament coming up here. And we will show you how to do an out-of-plane approach of a suprascapular nerve. This is an out-of-plane approach to a suprascapular nerve block. You can do the same procedure when you're doing a cryoneurolysis. Patients are sitting up or laying down lateral decubitus. You have trapezius, supraspinatus. Again, you have to know both out-of-plane and in-plane approaches, so don't be afraid of using your skills. And that's what we teach in our workshops, how to master your skills in out-of-plane. Axillary nerve. No, axillary nerve is not the axillary brachial plexus. It's actually a nerve that comes in the posterior part of brachial plexus, so in the innervated deltoid teres minor. So here's an ultrasound-guided axillary nerve block. So if somebody comes in and says, I have had a shoulder replacement or shoulder surgery, my pain is along the outside, along the deltoid, then you want to do an axillary nerve block before you can freeze it. So you find the posterior circumflex humeral artery around the neck of the humerus. You come in plane and inject for a diagnostic block or a cryoneurolysis. Lateral pectoral nerve is also an important shoulder innervator. If somebody gets an AC joint surgery, then you want to target the lateral pectoral nerve. It's between the pec major and minor. Lateral pectoral nerve and medial pectoral nerve are actually brachial plexus nerve. That's why we're talking here. Here's a video of lateral pectoral nerves done in plane. So here's the video with the pec major, minor, lateral pectoral nerve is here. We're not using a nerve stimulator because I could see the nerve really well. If you really are not sure whether it's the lateral pectoral nerve, you're most welcome to use a nerve stimulator to identify for sure that you are injecting perineurally around the lateral pectoral nerve. That's the lateral pectoral nerve visible now. So here's a depiction of how a cryoneurolysis of the lateral pectoral nerve would be. You'd use the same technique, use an angiocat, put the needle through, get a stim if you're not sure, because you just really want to be right next to the nerve. Cryoneurolysis targets in the trunk and pelvis. Everyone knows about intercostal nerves, ilioinguinal, genitofemoral, and pudendal nerves. Brief depiction of intercostal nerves. There are 11 intercostal nerves on each side, and there's the T12, which is not an intercostal nerve. It's called a subcostal nerve. Before you know which nerve to target, or let's say you have a 7th rib fracture, you want to be very precise when you're doing cryoneurolysis. You're using ultrasound. So I want to show you how to identify the rib level that you'll be targeting. And count here, rib 1, rib 2, rib 3, rib 4. So that's how you count from top to bottom. I'm going to show you another video that comes from below, from T12 up. So that's the T12, pleura, T11, T10, pleura, T9. So I can go down and say, I can confirm these rib positions. There's no pleura, absence of pleura up to 12. Here's another video of bottom to top counting. Go up cephalad, and we come back caudad. As you see, T12, and after there's no pleura, so that's a good indication that's T12. Intercostal sonoanatomy, you're injecting just about the pleura between the innermost intercostals and inner intercostals. Here's an in-plane approach, preferably done in plane. The reason why is you have pleura. The last thing any of the doctors who are doing these procedures want is a pneumothorax. If the patient already has a chest tube, then you're not really worried about it. So here's the rib pleura. We're getting our needle position to see it clearly as we advance. And we're trying to end up at the inferior border of the rib. This is usually the caudal and the cephalad areas. You want to see a spread of medicine with depression of the pleura, as you can see here. That tells you you're in the right space and got the nerve. Here's a depiction of how you would do cryoneurolysis. The probe goes through the angiocat and then freezes the nerve. These are images of how a cryoprobe. Here I marked out all the numbers. I'm going to be targeting this person bilateral T7, T8, T9 intercostal cryoneurolysis prior to starting the procedure. Here's a patient who was 95, broke his ribs. The only option left is for him to heal is this, because he can't tolerate opioids. He has COPD. So we did T6, T7 there, so the ribs are broken. So patient gets 90 days of relief. Here's another patient with postoperative neuralgia. I'm just showing you how these intercostal nerve cryoneurolysis is done in an outpatient procedure suites. And patients are all awake most of the time. They might get some sedation if they are needle phobic. Ilioinguinal nerve comes from L1. A lot of inguinal hernia repairs, a lot of post-hernia repair pain, which is seen with the primary care emergency physicians, and the patient just suffering. They get a nerve block which lasts a day. I mean, that just seems so silly when the pain lasts for days, if not weeks and months. So it's very important to identify your ilioinguinal nerves between the internal oblique and the transverse abdominis. So here's an outer plane approach. Again, I do my procedures out of plane and in plane. You have to be able to do both depending on the anatomy. So here's a needle coming in. You see tissue displacement. Target is here. This is the anterior superior iliac spine. So anywhere from 3 to 5 cc should be plenty to just get a diagnostic or a therapeutic block if you want to do the cryoneurolysis. Here's the ilioinguinal nerve block done in plane. Same thing, external oblique, internal oblique, we have transabdominus, so the needle and then the nerve. So your skills in doing nerve blocks are the same skills you would use in doing cryoneurolysis. So for example, this patient with post-inguinal herniorrhaphy comes in and we're doing a cryoneurolysis at that point because her pain is still there after 6 months. This should not be the case. These things should be done perioperatively or in the surgical suite or by in the family care, family physician's office or a pain doctor's office. Pudendal nerve blocks, where would I do pudendals? Well, you do a lot of colorectal surgeries, you do colorectal procedures, reconstructions of the genitalia. These are the procedures which can be very painful and very hard to treat. So pudendal nerve is usually medial to the internal pudendal arteries. So it's a little different than the vein artery nerve we were taught. So your artery is a very important anatomical landmark. It's usually between the sacrotuberous and sacrospinous ligament that you'll find. Here's an image of the ischial spine, and then the nerve, again, the neurovascular bundle is here. It's hard to visualize. So a lot of the times you must use a nerve stimulator so you get the rectal twitch, or if the patient's awake, they will tell you where the sensation, usually in the genitalia. So if the patient's asleep, you see a rectal twitch, which I'll show you some videos of. If the patient's awake, then you can ask the patient, hey, where are you feeling my stimulation? Is it close to the sciatic nerve or away from the sciatic nerve? Because sciatic nerve is in real proximity of the pudendal nerve. So if somebody has a very large buttocks and it's very difficult to identify with ultrasound, with the image being very poor, that often happens with the patients we serve who are obese. It makes it really challenging, but at the same time, these are the patients who really need pain relief because opioids are dangerous, can be life-threatening for them. So we actually describe the ischiorectal approach to pudendal nerve block when the patients are laying prone. So that can be applied for both females and males, because females, you can do a transvaginal, but how about a male? I don't want to do a rectal exam and then find the ischial spine. I would do a transgluteal ischiorectal approach. Here's a demonstration of that. So here's another patient with a very clear demonstration of how easy and quick these procedures are done. Though it's blind, if I have a very big patient, which is hard to see under ultrasound, and they're under anesthesia for these, usually local and max sedation for these cases, you're just going medial to the ischial tuberosity, you get an anal twitch. It's literally 30 seconds or less. So if you have an excuse of not doing a pudendal nerve block, then you need to come to one of our workshops to learn it. So we make it easy for you, you know? So same thing applies for pudendal cryoneurolysis. We do the same technique, use a nerve stimulator, get the anal twitch if they're asleep, because most of the patients are probably asleep for a pudendal cryoneurolysis because it can be painful and I need to see a rectal twitch. Here's another patient who had vulvodynia for 4 years. She gets 90% relief and 98% with cryoneurolysis. This treatment is effective. I don't know how much I can sell this. I don't have to sell. I think if you really want to help your patients, you can't just do a nerve block and leave and go home. That's not what we're supposed to be doing. And that's just how the society wants to, market ourselves, saying, listen, we're different. We want to make sure these post-surgical pain is covered both in the acute, subacute, and the chronic phases. Lower extremity targets, there are plenty of them. We'll talk about pericapsular nerve group. Again, these are nerves from the nerve branches from the obturator and femoral nerves, as you know. And they're sensory, so it's very similar to a nerve block, which obviously precedes a cryoneurolysis, when you're using a low frequency probe or sometimes even a high frequency if the patient is skinny, find the psoas tendon and go posterior to it. Here's an aberration where you might see fluid in and around the tendon. So you just want to see if there's a pathological reason for why somebody would have that. Here's a demonstration of a pericapsular nerve block done in plane. Here's the femoral artery, psoas tendon, needle coming in plane lateral to medial to go posterior to the psoas tendon. When we're doing the diagnostic, we usually use very low volumes, anywhere from 3 to 5. You don't want to flood the whole field. And if you're cryoing, you always do a nerve block prior to the cryo, so the cryo itself is painless. And also it gives the cryoneedle some fluid to freeze. Here's a demonstration of how a PEN cryoneurolysis would look like with the cryoprobe. Here's how the actual patient who had multiple, this is a veteran, right? He had 2 hip revisions. His pain is still there, can't walk, he's on opioids for 12 years. He comes to me and says, "Doc, what can I do? Because there's nothing wrong with my hip, but the surgeon, they don't want to operate. I don't want to go through surgery. What can we do?" I said, "Well, this is what we can do. And the technology is there. We just need to train more people." Here's a demonstration of a PEN cryoneurolysis. So we did the local anesthetic first. I'm using an 18-gauge angiocat. That's my insertion for the cryo probe. Again, this patient's awake, so we're going to do we had done a nerve block just prior to this. So he said, "Well, I got great relief, so let's go ahead and do the PEN cryoneurolysis." So slowly we can see it's not very clear, but this is where the ice wall starts forming in this area. Some of the pictures can be very clear. A lateral femoral cutaneous nerve, again, neuralgia parasitica, or if somebody has had a graft harvest done, it's a great target. You'll see very superficial, dividing in the anterior and posterior divisions, lateral to the sartorius. This is the sartorius, lateral to it between the tensor fascial lata and sartorius itself. Here's a simple nerve block to demonstrate. Again, if you need the skills to do your diagnostic, you need the skills to find your nerves, and the same skill is applied to do cryoneurolysis. So you're not learning anything new, you're just applying something new. So here's a diagnostic with a 27-gauge needle. The sensory nerve, I mean, if you feel like the image is not great, you can use a nerve stimulator as well, just to be 1,000% sure you are hitting these nerves that are targets. So here's sartorius, here's a tensor fascial lata, here's a little pocket of subcutaneous tissue with the lateral femoral cutaneous nerve. Saphenous nerve, sensory branch of the femoral. As you know, most people do these adductor canal blocks or saphenous nerve blocks in the mid-thigh under the sartorius. Again, you know, there's different ways of doing it. I'm going to show you an outer plane approach, which most people have either not seen or not done. But it's totally safe and fine to do these nerve blocks. If I can freeze a nerve, why are you worried about blocking a nerve? You know, it's a sensory nerve. I mean, the needle went in, you saw where it was. The block's done. We don't have to find a needle to do a nerve block. I keep telling people. I mean, a lot of people do in-plane. I do in-plane as well. And so do I mix it with our out-plane approach. In-plane takes more time. It's just like, okay, well, but if you need a longer needle track, just like you're doing a cryoneurolysis, you might want to do an in-plane approach. What if the patient is 400 pounds? Then you might want to do out-of-plane approach for cryoneurolysis because the needle is not long enough. So things you have to consider and have skills in your toolbox to do the right thing for the right patient who presents to you. Here's I'm trying to pierce the posterior fascia of the sartorius, I believe, and then give an injection. See, the medicine person in the area. It looks like it is. So here are different approaches to doing a nerve block, right? We have a mixed plane approach, in-plane and out-of-plane approach. So I don't really care, neither does the patient care whether you do it out-of-plane, in-plane, or mixed plane approach. So this is what we teach in our workshops, to be a better version of yourselves in just upping the game when you're doing these nerve blocks and nerve procedures of cryoneurolysis. Here's a cryoneurolysis image of how a saphenous nerve cryo. I've done quite a few. The patients respond really well. The only thing is we just tell them, hey, you're going to be numb with the distribution. And they're okay with it instead of being in pain. Genicular nerves is something I believe you all might have known that cryo is routinely done because the orthopedic surgeons want them to be done 2 to 3 weeks prior to the surgeries. Here's a depiction of genicular nerves being done, superior medial, superior lateral, and inferior medial genicular nerves. Here's genicular nerve block. Here's the periosteum, femur. We have a genicular artery. So you just go right perivascular inject. So this is an out of plane approach, as you can see. You don't even see the needle. I just hit the bone and start injecting. Here's a demonstration of the cryoneurolysis. I actually did this patient who had multiple surgeries, is 35, an inferior lateral genicular nerve cryoneurolysis. He gets 100% relief. He hasn't seen me in 9 months now. So again, simple things. Do a diagnostic where we are. Do the cryoneurolysis, safe, effective. Innervation of the foot and ankle. We know there's 5 nerves, 4 from the sciatic, 1 from the femoral. Here's a superficial peroneal nerve block. Patient's lateral decubitus with the leg on the side. You see 2 muscles. Don't remember the name. That's okay. Here's the nerve. Needle. Another one which is probably much better. So here's the nerve really well, but this was a CRPS patient who comes in with a very thick superficial peroneal nerve. Again, initially you have to do a nerve block to see if the pain eases, and then a cryoneurolysis of the superficial peroneal is an easy procedure because you already know how to do a nerve block. If you know how to do a nerve block, you can do cryoneurolysis. It's as simple as that. Here's a patient with cryoneurolysis of the superficial fibular nerve. Foot pain, very common, podiatric surgeries. Deep peroneal nerve also is a target. Let's say the patient complains of pain in the web space between the great toe and the second toe, then yeah. I'm doing an out-of-plane approach. Needles coming up, inject, the nerve block's done. Speed and accuracy, it's precision medicine for cryoneurolysis. You have to be so precise. Here's a couple of patients who have excellent results. They have CRPS of the foot. They haven't seen, this gentleman hasn't seen me for 2 years. This one hasn't seen me for 3 months. The ice ball, that's actually visible in the ultrasound. Sural nerve, again, a fully sensory nerve that can be easily targeted behind the calves. Here's the gastrocsoleus sural nerve. Let's do a nerve block here. Out of plane, again, I want to make sure you're comfortable. Let's say you're not comfortable. Go to a workshop which we offer. We teach out of plane all day, every day. Because you need to have those skills to be able to do cryoneurolysis and peripheral nerve blocks. Here's a sural nerve for an amputee. Again, same thing, post-surgical pain. Years of pain, they come to me. It's a shame that we are here. It should not be the case. The patients should have gotten a cryoneurolysis done in their subacute transitional pain phase. Guess what? You can actually freeze motor nerves. Here's a patient with an amputation below knee. We're freezing the tibial nerve, and he gets 60 days, 90 days sometimes, and then comes and repeats the same process. He uses his prosthesis. There's no problem walking. So if you can freeze the tibial nerve, I mean, we are somewhere very effective. Here's a demonstration of how an amputee can benefit from cryoneurolysis of the tibial nerve. Post-amputation pain is real. I feel so bad and sorry for these people. All the anesthesiologists just do one block and think it's their godsend in doing this block, and the pain comes right back the next day. That's not what we're here for. We are here to control the pain for months and years to come. And it's a shame these patients have to find us. Not many people do it out there. Why so? So here's an amputee, right? He can't wear his prosthesis. We said, okay, let's do a tibial nerve block and do a cryoneurolysis of your tibial nerve. We numb the skin now. I'm using an 18-gauge insertion catheter, IV catheter. Cryo probe goes in. We're going in plane here. That's the tibial nerve. So I'm pressing the button now. Freeze it. You can see the ice ball form immediately. So the beauty of ice is amazing to watch. And I welcome you all to the world of cryoneurolysis. I can't tell you more how excited I am about this, what we can do for our patients, avoid opioids, have a better quality of life, and not suffer. And it's instantaneous. The guy starts walking. Pain-free, and he hasn't seen me in 5 months now. So, in summary, it's a safe and effective procedure. It's 100% reversible. Type 2 nerve injury. Post-surgical pain does not stop with the regional anesthetic block. It's a shame the society still talk about blocks being the biggest thing that was invented in anesthesia, which is not. It's a shame because the block wears off in a day or two. So what's the point of doing it when the pain comes back day two? You're not doing a good job. And that's why we have a society that does promote all these essential skills that are needed to promote a better pain relief in the acute, subacute, and chronic state. Well, we have a workshop in 10 days. If somebody wants to register and come to us, we can talk about all plain nerve blocks if you're interested. It's in Tampa under Ultrasound Experts. We talked about cryoneurolysis workshops. We're the only society in the world, in the country, to do these cryoneurolysis workshops in the United States. One's coming in October in Tampa, warm weather. You want to go to San Diego in February, we're there in San Diego. So I'm going to leave this QR code so you can get more information for people who did not see this QR code at the beginning of the presentation. So a few seconds so that people can scan this to learn more about these workshops. Again, I'm only touching a basics of it. There is much more to do in cryoneurolysis than just listening to a webinar and getting started. So I strongly recommend you attend one of these workshops to get familiarized, get comfortable, start advocating for cryoneurolysis in your practices. It's such a great tool to have to avoid opioids. Last but not least, we are having the annual conference where we'll be talking about cryoneurolysis, every other modality that can help patients up in post-surgical pain, both acute, subacute, and chronic. So I welcome you all to come to Tampa. It's going to be a wonderful presentation with world-class faculty, 2 workshops, one focusing on the acute post-surgical pain and one focusing on chronic post-surgical pain, both at ultrasound, half a day, world-class faculty. You don't want to miss this. Here's the QR code. I will give you a few seconds to scan, and I hope to see you guys in Tampa in December. Again, this is something new. I understand we are a newer society, but there's a reason why we have a society like this, to promote a better post-surgical pain management, and I can't emphasize that more. That will be the end of the presentation. I'm going to take questions if you have. The video recording of this will be available pretty soon. Let me log. I know my exit. Okay, exit. Nick, can you exit me, please? I'm just going to exit back.
Yeah, you're coming through.
Oh, there you go. Okay.
That's fine. We don't have anything in the Q&A yet.
Okay. There's any, then yes.
Here we go. Are you able to pick that up on your side?
Yeah, I'll try. Yeah. What is the average duration of effect that you see post-procedure? Can you please expand on number of lesions, please? This is a question from Ibrahim Ali. The average duration we see is about 3 months. It can last months and many years in many other patients. So as data gets collected, we will know better how long. Is there any risk for motor loss when doing cryogenic PENG blocks? Again, PENG blocks are specially done for sensory nerves, right? When the nerve block doesn't cause motor loss, we don't expect a cryoneurolysis to cause any motor loss as such. So what is your experience with phantom pain, please? So as I mentioned in my talk and also the video, the patient had pain in his stump and also had some phantom pain. So I think it's an absolute indication to do a cryoneurolysis in patients with phantom pain, which most likely will help. Is there any concerns with cryo when you have vascular structure nearby, the femoral artery near the saphenous? As I mentioned, they actually looked at the histology 8 weeks to 32 weeks after a cryo was done, and there was no vascular injury or damage. Most of the vessels were back to normal. Also, the arteries have very thick wall, so just a little freeze for about 50 seconds would not puncture the artery unless it's a very weak artery, which usually arteries are not. What is the effect from pulsed RF compared with cryo? I've done a couple of pulsed RF. Cryo is superior than any pulsed RF out there. Pulsed RF sounds like a joke to me, to be honest. No offense, but it just doesn't work in most of the nerves that we apply to. There is data out there that some of the nerves respond to it, but when I have a cryo, which is more effective, there's more guarantee in getting pain relief, then I would choose something that's more reliable versus pulsed RF, which might or might not. And also pulsed RF doesn't come in handheld devices, so cryo can be carried on anywhere in your hospital, outpatient procedures, anywhere. Missed the beginning. What is the actual process? It is the formation of ice that caused the neurolysis. If so, how close the needle tip has to be to the nerve? I'm sorry you missed it, but this recording will be available to you next week, so you can always look at it. The needle tip has to be on the nerve. There is no ifs and buts. So the needle nerve contact must be there. Otherwise, it's not going to help. The ice tip will be, the ice ball will form for, pretty thick. Maybe if you're in the vicinity, you might still capture it. But if you really want to capture it, you want to be on the tip. The tip should be on the needle, on the nerve itself. Interesting and very, very nice questions we have here. I think we're at the end of the presentation. I hope you enjoyed the presentation. I hope you come to one of our workshops and learn more on the Society conference later in the year. If you have any questions, email us. Oh, there's somebody else here. Carol Novak. I started performing cryo procedures in the early 90s and not found much more payer coverage now compared to then. Who is actually paying for the service? Good question, Dr. Carol Novak. Medicare passed a law as of January 2025. Cryoneurolysis is part of the No Pain Act and will be covered by Medicare. So it's dependent on your coverage locally. So please check with your local insurance coverage and local Medicare about coverage. So that act is legal now. It's a law of the land. So that's a very promising thing. Can you please expand on the number of lesions in average? So if I'm doing a peripheral nerve for pain, we usually do about 3 to 4 lesions. Each lesion is about 106 seconds on the eye-aware device, which the lesions duration changes depending on the device you might be using, which the manufacturer can give you more information about. Again, these are the things, probably nitty-gritty things you might want to come and learn in a workshop, because that's when we discuss in depth. We have a few questions. So all questions have been answered. Looks like 8:44. Everybody, have a good night. Thank you for your time. Thank you for spending the evening with us. Nick, any questions?
No, we'll follow up with everybody as soon as we have the recording available, and we'll also make any of the links available for anybody that wants to join the conference, the course, or find out more about the society.
Beautiful. Everybody have a good night. Good night, Nick.
Take care.